Hello guys, my name is Chris and I was a final year medical student in Newcastle University, but now I'm gonna become a doctor in Northern Ireland. So today I want to start making a series of video on how to pass your Mosler exam. In March time, I had my first attempt on Mosler exam. I failed it. When seeing the results, there was a big red, like the main fails on my results, and as you can see that the results were pretty bad compared to the mass majority of my cohort. I had to spend another 2 weeks to study and go through the exam. It was a really painful experience when seeing all my friends happily pass their exams during March time, while me have to go through another studies again, do more studies, more stressful times, and still unsure whether I'm able to pass it or not. After a period of harsh reflections and feedbacks from other people, my results is like this, which released about 4 days ago, I think. And as you can see that I have a great improvement on each domain of my Mosler exam. So today I summarized everything I know about Mosler exams into a series of videos. I will go through a history examination, which is 15 minutes in Newcastle University. I'll go through the interrogation period, which is the questioning part. Well, it's 7 minutes in Newcastle University, and I'll talk through the summarizing, the presenting histories, differential diagnosis, as well as the investigations and management. We'll talk a little bit about communication skill stations, so explaining results, breaking bad news, and finally the A to E assessments. Now, I hope that by summarizing and organizing everything into structures, you will be able to pass the exam in one go. You don't have to go through the lonely time like me. I have to study while everyone is planning about their holidays. So more on today's. So today we'll talk about the history takings, so the general history as well as the obs and gynae, peds, mental health, examination, some mindsets when history taking, as well as my results. So I'll go through the actual feedback by the examiners on my results, and finally I'll probably touch a little bit on how I'll show you how I prepare during the 3-minute prep time. So, okay, so first part of the history taking. Obviously, we know that there's a general structure of presenting complaints, eyes, personal history, and social history. So going into more details on presenting complaints, so we all know that if a patient has some kind of pain, we use a Socrates, right? But then it actually applies for everything. So, for example, if the patient comes in with a shortness of breath, then we can use Socrates to ask some details on it. So site, it doesn't apply. Character, probably like whether it's an exertion or not. Radiation doesn't apply. Onset, how long has it been? Is it acute, like chest infection, or long term, like lung cancer? Time, like a pattern. So for example, asthma is worse at night, right? And exacerbations, other than exertional, or probably PND, so paroxysmal nocturnal dyspnea. If the patient says that I wake up in the middle of night gasping for air, then that's more leans towards the heart failure, right? And after that, we'll start asking the associated symptoms. So the A in Socrates will ask associated symptoms. So you'll check the cardinal symptoms. So let's say the patient has shortness of breath, you start asking the cardinal symptoms like cardiovascular and respiratory, right? If the patient has weakness, then you'll check neurological and connective tissue disease, as well as some kind of trauma and infections. The thing that I learned mainly after I failed my exams and start revising and updating on my history taking is the rule in and rule out. So what it means is that you will ask specific questions on the medical conditions, so that your history will you'll make sure that you are rolling in that thing and rolling out other things. What I mean by that is that, let's say you think this patient has myasthenia gravis, so with the weakness, right? Then you will ask specific questions to roll that in. So let's say, myasthenia gravis, so fatigability. So did you notice that when you chew things, like after eating, your jaw is weaker than normal? Do you notice that you have double visions around late night? Do you feel like if you use the thing more often, then your hand is weaker than usual? That's rolling in. And then roll out. So other than myasthenia gravis, you can think that this patient might have multiple sclerosis, MND, potential stroke, connective tissue disease like SLEs, general infections, things like that. Then by rolling out, you would check. So multiple sclerosis, you ask any optic neuritis or any vision changes, color vision changes. Is there any multiple episodes of this? Bowel problems, urinary problems. MND is usually family history, so you will check that during family history. Stroke, any slur speech, is there any facial weakness, vision changes. So you will start asking specific questions for each medical conditions, so that first of all, you're rolling in that thing and rolling out other things, as well as allowing the examiner to know that, oh, I know this medical student is checking the multiple sclerosis, or that's question for myasthenia gravis. Then they'll be able to tick on the feedback and on their iPad. This medical student would know what he's talking about. And after that, always check the red flags. So that's usually it's cancer, right? So you check unintentional weight loss, tiredness, night sweats, potential recent travels. If back pain, you also check cordon equina, so saddle amnesia, sciatica. If headache, then you also check for any subarachnoid hemorrhage, like thunderclap headaches in the back, or GCA, so giant cell arteritis, any pain when combing their hair, jaw collocations. Those are the red flags for certain type of presenting complaints that you would double check. Sometimes I do ask about the impact on life if the patient is stressing it all the time, but then usually I ask it during the social histories. If you don't have enough time, because we only have 15 minutes in history taking / examination, right? So I would often ask this way, is there any issue with passing urine? They'll say no. You can add on to it by saying, oh, just clarify, is there no burning sensations, no increased frequency, no blood inside, right? And no. Then, yeah, make sure that there's no problem with his urine problems. Eyes is a special thing for Newcastle University. They love eyes. Examiners loves eyes. It's like a treasure for Newcastle professors. If you don't do eyes, your history is not completed. So eyes means idea, concerns, and expectations. The idea, usually I ask it this way. So it sounds like you have been experiencing this for a while, or this came on quite suddenly in this morning. Do you have any thoughts about what this might be? And then concerns. So if they stressed previously about a certain concerns, for example, oh, I'm really worried that it's cancer, things like that, then you could repeat it again. So you mentioned that you're quite worried about cancer. Is there any other things that you're worried about? Or if they didn't say anything, then you could just say, is there any particular worries that you have in regards to all those symptoms going on? And finally, expectations. After trialing all kinds of different ways of asking expectations, probably the best way, from my own personal view, is other than finding out what this is and treat it, is there any particular things you hope for from today, or anything else you want me to do for you? That's probably the best, most natural way of putting eyes into your history taking. And at this point in time, I usually add a signpost into the history taking, because apparently there's a signposting segment in the examiner's iPad. So if you do it, they'll take it. Job done, isn't it? I usually say it this way. So I ask quite a lot of questions about your symptoms. We'll move on to your past medical history, medications, if that's alright. The signposting, good. You don't have to touch it again. And past medical history, medication-wise, so you check for any medical conditions that they have. Usually they will show you a medication that they are currently taking. So if you see like furosemide, probably heart failure, atorvastatins, high cholesterol. So you could probably guess what kind of problems he has. If the patient is easily very chatty, then just in case, you could just double check the system. So respiratory, so for example, shortness of breath, you check any heart problems, any lung problems, and then any cancers, any surgeries done in that area before, then that'll be done for past medical history. Medication wise, obviously you check any medications, any other new medications. And if you think that, for example, if a COPD patient, then you could probably ask about whether your COPD is well controlled enough, and is there any change in your recent medications that might lead to your recent exacerbation of COPD, right? So those are the things you could double check. And the main reason why you ask past medical history and medication, obviously, is for risk factor and complications. So keep that in mind, because when you're summarizing the patient or explaining your differential diagnosis, you can use those information added into your differentials so that the examiner know that, or you're actually thinking about the risk factors and complications while you're taking history. So it makes you look smarter. And family history, same as well. You'll double check any similar system problems. The patient has weakness, any MND in the family, any muscle weakness in the family, any surgeries done, any cancers. Finally, going on to the social history, I had a friend who taught me about this acronym called STACE DJPT. So it represents smoke, alcohol, drug, activity, care, exercise, driving. And driving is very important for neurological problems, especially if the leg is weak. You have to check whether they still drive or not. As well as if a patient has eye problems, then you need to check that as well. So stroke problems, multiple sclerosis, the optic neuritis problems, eye in general, cataract, glaucoma, you have to check for any drivings, because we're being safe, right? Or we're very safe. Job is important sometimes, but you could double check. For example, if the patient has shortness of breath, then you might want to check what job he's doing. So in one of our exams, although it's not a Mosler exam or not OSCE exam, it was a written exam. But the patient is a 50-ish years old, no, 30-ish years old male with a shortness of breath, and he's a baker. So the investigation's done. The diagnosis he has is occupational asthma. That's why job is very important for checking what kind of diagnosis he has. So for example, if shortness of breath, you double check the patient whether he has a exposure to asbestosis, coal mining, silicosis for any potential lung cancers, or chemicals for any skin cancers. Those will help you when you're presenting your histories and presenting your differential diagnosis. Pets and travels, is important, right? Tachia and unit of alcohol. I've never been asked about how to calculate it, but just keep it in back of your mind how to do it. So tachia is X year divided by 10. So if I smoke 20 years, so 20 divided by 10 is 2. And then if I smoke 40 cigarettes a day, one package is 20, so that'll be 2 package. So 2 times 2, 4, so 4 pack years. And units of alcohol, and I never been asked by this, but X percentage, Y mole divided by 1,000. Just do your own, just check Geeky Medic. You'll be able to learn that quite easily. It's a simple calculation. And going on to the examination, in terms of the timing wise, we only have 15 minutes on history and examination, right? So I speak quite fast and I do quite a thorough history. So my history is usually about 8 to 9 minutes, leaving me around 6 minutes for examination. It's not much time, but then when I start my year 5, I keep asking all the foundation doctors as well as the teaching fellows whether I should do a full examination. And everyone says different answers. You just do like focus one, and then certain people say, no, you have to do the full examination. So after doing 8 stations in my first attempt and then 8 stations in my second attempt, so overall roughly around 16 stations, I can say that they prefer you to do a full examination, which means that when doing GI exam, you will have to look at the patient's hand, but you can do it quite fast, just no, nothing. And 2 things to notify. First of all is look at the room for hints. There was one patient who has COPD, and on the desk there was a spacer as well as a inhaler. So which, when I walked inside, immediately I knew that probably it's either asthma or COPD. So look at the room generally. So either for inhalers, medications, or crutches like walking aids. Those are quite helpful for checking what kind of differential, so how much impact on their life with a walking aid. The other thing I want to mention is positive sign identify. So first of all is when you feel around the joints or abdomen, you should look at the patient's face, and you have to look at the patient's face, and you need to look at their face very obviously. You have to feel around it and look, and then with your head turning almost 180 degrees so that the examiner knows that you're looking at their face. Because I was penalized for not looking at patient's face, even though my eyes is like looking that way at the patient's face while feeling the abdomen. He didn't see it, so you need to actually turn your head. So that means that when doing MSK exams, so like hand exams, hip exams, shoulder exams, as well as abdominal exams, just make sure that you make it quite obvious that you're staring at their eyes for any potential like this kind of events. Another thing is pulse. Pulse is very important, and usually previously I just feel for it, like feel the radial pulse. It's regular, it should be fine. But then there was once in year 4, the patient actually had a AF, it's an atrial fibrillation, even though it's a GI, so abdominal problem. I didn't pick it up, and apparently the examiner wasn't really happy about it. So actually feel for it, because it might lead to your add-on to a differential diagnosis. And another thing is that during my resit in Mosler exam, I had a patient with peripheral vascular disease, and feeling for the pulse around the dorsalis pediis is really difficult. I didn't do much practice on it, and that patient is about 80 years old. It's difficult already, as well as my shitty technique. I couldn't feel anything, but then I wasn't, but my hands were shaking because the time is ticking. I only have 15 minutes and there's not much time left already. So my hands were shaking a little bit. And I misinterpreted as that being the pulse of the patient's dorsalis pediis. But I couldn't feel anything on posterior tibial pulse. So I was really confused. And I said, when presenting it, I said there's both of them present, because I didn't know what I was doing. I feel for the pulse. I think I feel it, but I don't dare to say it's not there or it is there. So when checking the pulse, make sure if you don't feel it, just say you don't feel it, it's fine. And make sure that you practice the dorsalis pediis as well as posterior tibial pulse, because they are quite difficult to feel, but then they are very important for peripheral vascular disease. So practice on that. Over here, I summarize all the examination I can think of that you might be asked to do. So neurological, and neurolimbs, cranial, and neurolimbs means doing motor and sensories. Cardiovascular, make sure that you learn about the heart murmurs. I didn't do much, and in my first attempt of motor exam, I had a patient with probably mitral valve regurg, I think. And I didn't know at all. And as a result, my examination, out of 3 points, I only got 1 because I couldn't identify any heart murmurs. So if you got a chance to hear a heart murmurs in hospital, just stay and make sure that you get some practice on that. GI and respiratory is quite easy because we have been doing it since year 3. I've done it like 2,000 times already. Eye and ears, not much, but make sure that when doing eyes, you know the how to interpret the peripheral visions, because they could ask you where the lesion is according to your results, and that's what some of my friends in Newcastle got. For diabetes fluid, nothing much. Thyroid, post-exam is very difficult. And MSK, there's quite a lot. So hand, elbow, shoulder, hip, knee, feet, and spine. A few special ones that you might be asked to do to add on to your examination is myasthenia gravis and Parkinson's disease. I don't know any other special exams for any other conditions, but there might be. So for myasthenia gravis, you check the fatigabilities, right? So first of all, you ask the patient to blink, like keep blinking, and then you'll notice that their eyelids start like drooling, like this. Or you can do the chicken wing, and then their hands will be like very difficult on this side. For Parkinson's disease, you ask the patient to do this, and then they will slowly get slower, like that. As well as postural hypotension, so you stand by the patient, ask them to stand up, and they'll feel a bit of dizziness. Finally, for Parkinson's, you would also ask the patient to stand up. So you stand up, and then you stand behind the patient, right next to the wall, so that you don't get pulled away or fall alongside with the patient. You pull the patient backwards, and they will take multiple steps going backwards. Like they'll keep falling backwards, going backwards, and they will not stop. As well as finally for Parkinson's, you'll check their gait, so shuffling gait with multiple steps while turning. Those are the things you'll check. So my recommendation is that if you think that the patient has Parkinson's disease, you do the special exam first, and then do a full neurological exam just to complete the examination, alright? And final thing to add on to examination is that, sometimes geeky medics, at the end of the summarizations, they say that I would do for completeness of the examination. So let's say a GI exam, I would examine external orifices, PR exam, external genitalia, any hernias. Make sure you say that. It's mainly for the completeness for examiners to take off on your examination part. We have done the history taking, general history taking and examinations. Before we go on to the feedback on my results, I'll just go through the obs and gynae and mental health as well as the peds history. We'll start from obs and gynae because it's more complex and there's more things to be aware of in these structures. If you got obs and gynae history, you are fighting against time. There's so many things you want to ask, so many things you have to ask, and a lot of sensitive questions. So first of all, we'll talk about obstetric history. So when you go in, you'll start introducing yourself. Hello, my name is Chris. I'm one of the doctors here. Before we start, can I double check some questions about your current pregnancies? And GMP, so G means gravida, how many pregnancies have you had, including ask it sensitively. If you wish to, if you want to include miscarriages, you can also ask as well. Just a question we ask. Is there any miscarriages before? No? Okay. And then parities. So how many deliveries and any stillbirth by any chance? But usually I don't really ask it. Just ask how many pregnancies, how many deliveries, and then any miscarriages. You're going to ask how many weeks she is in. So she might say 24 weeks. And any scans, whether they are normal or not, any complications during this pregnancy, is she high risk or low risk, and finally, any fetal movement changes. After that part is done, then we'll go on to presenting complaints. So how can I help today? And she might say, let's say, oh, hi doctor, I noticed that my skin is more itchy than normal. It's affecting my sleep, and I just want some medications today. Then you start the Socrates. So how long, when did it start? Anything makes it better, anything makes it worse? Has this happened before? Things like that. Any skin conditions? And then still double check the bowels and urinary problems. It's more of a general checking screen and make sure she's fine. No potential UTI that could threaten the pregnancies. If you don't know what might be going on, you can do a head to toe. So just to make sure that you're alright, we'll go through a list of symptoms from head to toe. Okay, so headache, eye problems, throat, not really probably, shortness of breath, heart problems, GI problems, any skin changes. And she might say, oh, I noticed my skin is yellower than normal. Then you think that, oh, okay, so this is probably a obstetric cholestasis, right? So that presenting complaint is done. And you'll go on to some questions about previous pregnancies. So any issues with previous pregnancies, delivery mode, any complications, and then eyes. In terms of the obstetric history, so there are MSC, shortness of breath. This is the acronym that I was taught by my friends about the things that you should technically cover in gynae and obstetric histories. So menstrual cycle, not really important. As for STI, if you think that there might be, for example, if a patient noticed some abnormal discharge from vagina, then you might need to ask some STIs. Contraceptions is just more of a completeness. You double check that. And smear tests is very important for cervical cancer. Obstetric, we're doing obstetric history already, so you obviously check it. B for bowels and urinaries. It's more of a completeness. Make sure that there's no potential UTI going on threatening the pregnancies. That's everything for obstetric. And going on to gynae. So gynae history is hard, not only because there's tons of things to cover. You want to be sensitive when talking about sexual health histories and explain why you're doing it, why you're asking it, as well as you might not know this is even a gynae history. Let's say this patient has a 25 years old with a right-sided iliac fossa abdominal pain. It could be appendicitis, it could be kidney stones, pyelonephritis. It can be anything, to be honest. Identifying it is also a hard part about gynae histories. So when going in, the structure is again the same thing to general history. So presenting complaints, cardinal symptoms, roll in, roll out. And then if you think that this is a gynae history, then you will signpost it. So let's say, so let's say it's a 25 years old right iliac fossa pain, right? And you have checked no vomit, no bowel problems, no urinary problems. Then you will ask, okay, so because the symptoms that you're experiencing, it could be related to your vagina, ovaries. Is it alright if I ask some women health problem questions? Would that be alright? And they'll usually say yes. So first of all, you go for a smear test. So smear test wise, when was the last smear test? Was it normal? Good, normal. And then sexual health history, you will signpost it. So again, like just want to check because of the symptoms related to your vagina. Is it alright if I ask some questions about your sexual health histories. Would that be alright? And that's fine. And ask with fluency as well as no awkwardness. So yeah, ask, are you currently in a sexually active relationship? Yes. Okay. And is it a regular partner? Yeah. Is it same sex or opposite sex? Opposite sex. And then go on to checking STIs. So just a question that we ask all patients. Have you ever had any sexual transmitted infections? No. Okay. And then pain. Is there any pain during sex? Is there any pain after sex? Is there any bleeding afterwards or abnormal discharge? Nothing. Okay. Nothing over there. You thank the patient for that. So thank you very much for telling me that. That's everything I want to ask in sexual health histories. Thank you. And then you go on to menstrual periods and pregnancies. So menstrual period wise, when was the last menstrual period? Is there any abnormalities recently? How long? How often? And pregnancy wise, again, just briefly touch it. How many pregnancies? Any issues? Any complications? And after that, you have covered almost everything for the obs and gynae histories. We done menstrual, we done STI, we have contraceptions left to be asked. So after eyes, past medical history and medication. So medication wise, just double check any contraceptions. So if they're using any Mirena coils or implants, then you think there's a higher risk of ectopic pregnancies. So that's why you would double check on contraceptions. So that's everything for obstetric and gynae histories. We'll go on to mental health. And the difficult part of mental health is you have to ask the question very sensitively so that the patient doesn't feel like you're insulting them or attacking on their emotions. When I first learned mental health histories, there was a patient in GP who has low mood. And after checking for potential hypothyroid, I started asking about mental health histories. And at that time, there was still a little bit of stereotypes for mental health. So I know I have to be very careful. But then I haven't done much practice on it. So when asking it, I start asking, do you have any mental health problems? And that just triggered the patients. It's just boom, a bomb exploded. I had to ask my GP to come and save me. So the phrasing of your words is really important for mental health history, as well as make sure that risk assessment is checked. Probably on the examiner's iPad, there's a big red risk assessments square for them to tick. So if you ask them, they tick it. If you don't ask them, probably they fail you on history taking. So those are the two things, phrasing and risk assessments. So going in, you obviously introduce yourself, presenting complaints at Socrates. And if you think that it's a mental health history, you will check the mood, perception, thoughts, and insights, as well as memories to make sure that there's no potential dementias if the patient is quite old. Suicidal history is quite difficult. Since year 3, year 4, and year 5, I have not yet had any mental capacity assessments or suicidal history exams, but it will be quite difficult and you might need to ask some sensitive and difficult questions to them. Physical symptoms is mainly to see whether there's any potential anxieties or head trauma, head masses, hypoglycemias. So you could potentially start with the physical symptoms and then slowly go on to mental health, or you can start with mental health if the patient has quite a good insight on his problem. For asking symptoms of mental health, you could use my friend John technique, which is taught by the GP who saved me from the miserable events when talking to a patient about mental health. So she was saying that you could use my friend John's technique, which is some people with low mood or similar experience like you may notice they see things that people might not see, hear things that people might not hear, thought insertions, thought withdrawal, their thoughts being broadcasted into the room. You feel like you have similar experience before, then that'll make them feel less interrogated and flow better in the history taking, a better report I would say. Oh, and then when it comes to anxieties, you will still check the specific questions, so the physical symptoms as well as the mental symptoms, but you will also need to check the which type of anxiety the patient has, whether it's a general anxiety disorder, a panic attack, PTSD, potential phobia, or OCDs. So those are specific questions that you need to check. And not to mention about the depressions, so anhedonia, low mood, low energy. Those are so the criteria of the DSM. I think it's DSM-5, isn't it? Those are the things that you will need to ask when taking the history, so that you can show off your knowledge when presenting the history back and talk about your differential diagnosis. Risk assessments, probably use my friend John technique, is the most gentle way of asking it. So saying like, some people with similar experience like you may notice that they want to take their own life. Do you feel like you have similar experience? Thoughts about harming yourself, thoughts about harming others. If they say no, thank you for telling me that, and start checking for eyes. So do you have any thoughts about what this might be? Is there any particular worries that you have, expectations, and also check for any triggers, so life events. Is there any recent change in your life, like stress in your work, more projects to do in your job? Past medical history, medication, and social histories. Sometimes childhood history might be in the mark scheme of examiner's iPad, so double check on that. If you got time, just briefly touch it. Like, is there any involvement with the police? So this is the question we ask all patients. Like, is there any involvement with the police? And some people with your experience may notice that when looking back in your life, in the childhood, there might be a big events like divorce or potential accidents. Do you have a similar experience before? Finally, checking for any insights of the patient, because you want to present the MSE examination, right? So you would say like, if doctors or if someone tells you that it might be related to your mood, how would you feel? And certain patient will be like, oh, that's bullshit. Like, it's obviously my heart. Like, I got experience of heart palpitations and tremors. It must be related to my heart. Why are you talking about mental health? Then you know that it's probably a low insight. It'll be quite difficult to talk about mental health when it comes to the management. Or some patients will be more chill and relaxed, saying that, oh, okay, yeah, I've been quite stressful. I'm a teacher and the exam is coming in. I need to prepare a lot of things. Then it will be a full insight for them. HEADS assessment is something that we got during our March examination. So it was a event where we have to talk to a dad, where his around 21 years old daughter has been found probably unconscious in a party and sent to an A&E. And our job is to talk to dad and see whether the daughter is safe to be discharged home. And what our job is to do a HEADS assessment. So ask dad about home situation, education, potential drug use, suicidal problems. I would say it was quite difficult. And even with my current knowledge, going back in time, and if I go back into that station, it will still be quite difficult, because whatever I ask that, he's either I don't know or no problems. So I don't really know what kind of plot or stories the dad has in his mind. But then our job is to make sure that we double check everything, to make sure that daughter has no problem at home and anywhere else, and she's safe at home, safe to be discharged home. So finally, PEDS. So PEDS history is generally a bit simpler. We just have to add on to binds. So birth, immunization, nutrition, developmental milestones, and social health. But the difficult part about PEDS history is the vague symptoms, and as well as you are talking to the parents. So parents probably doesn't know what kind of symptoms the child is experiencing. So other than presenting complaints, Socrates, you might need to check for head to toes. So I was taught by my GP that if the child is less than 5 or less than 7, you'll do a head to toe all the time. So headache, eye problems, throat infections, chest infections, breathing, abdominal stuff. Skin and recent travels are more important in childs. For example, CMPA, so cow's milk protein allergies, the urticaria, it's quite an obvious sign, isn't it? And recent travel is mainly for example, like malarias, dengue, potential like petechiae, like meningitis. Yeah, it's mainly for those kind of general vague symptoms. You don't know what's going on. You ask the patient, ask the parents, oh, have you been traveling anywhere recently? And they tell you, by the way, we have been traveling to Africa 2 weeks ago, and there was no mosquito tent or mosquito sprays used. Then you'll be thinking about malaria. After eyes, you check the binds. So birth is mainly for checking potential like issues during pregnancies, like respiratory problems. So you will ask how many weeks, any issue during pregnancies, any issue after deliveries, any ITU services involved. Immunization, nutrition is quite self-explanatory. Developmental milestones is a hard one because when I first learned about peace history, I know that I need to ask about binds, but then I didn't really know how to ask developmental milestones in a understandable way. So the first few history taking, I asked after the nutrition, I asked, is there any concerns about, for example, like baby John's developmental milestones? And the most common reply I got is a confused face plus a, what do you mean? What do you mean? So now, when asking developmental milestones, just ask it in a more general way. So such as, do you have any concerns about how baby John interacts or play with friends, siblings? Usually they'll say no. But a general summary of developmental milestone is like this. For 6 weeks, you have a head control and able to track the object with your eyes. 6 weeks, 6 months, just imagine a child sitting with a hunchback and then holding a brick and putting it into the mouth. So they have a palmar grasp and able to put object to the mouth. 9 months, imagine a child girl, standing behind his dad. So she's standing already, standing behind dad because she's having a stranger danger and holding a pencil. So she has a pencil grip already. 12 months, they start walking, able to talk 3 words. 2 years old, start running around. 3 years old for bladder control, but usually get up to 5 years old. If a child is more than 5 years old, but still haven't control with their bladders, that's something that we need to be more careful about. And finally, 4 years old is the most noisy time, like best friends and tell stories non-stop. When it comes to diets, so nutrition, another thing to add on to it is that we would check what kind of diets the baby is eating or the child is eating. Because, for example, if the child has celiac disease, then it will present with a poor weight gain. So you might need to check for celiac disease. What does he eat? Does he eat bread? Does he eat biscuits? And then that leads to diarrhea and constipations. Or cow's milk, protein allergies, any urticarias, bottle fed. Does mom drink milk? Is it breastfeed? Those kind of things will be able to help you check whether it's food related, like allergies, intolerance kind of diagnosis. So we have talked a lot about the general history taking examinations as well as the special history takings, such as the obstetric, gynae, peds, and mental health. What we'll do now is I will go through my results, so actual result feedbacks from the one that I passed. We'll have a look at the history taking and examination feedbacks. So we'll have a look this is my Newcastle University feedback on the resit exam. So we have 5 sections. So information gathering, that's the history taking. Procedure is the examination. Communication skills is how I treat the patients. Like either I'm pathetic enough, whether I talk to the patient slow enough, doesn't rush the patient without any jargons, whether I'm a good person enough, whether I'm a good doctor. So checking the first station, it was a stroke review patient. So the patient had a stroke probably last year and came back for a review. And you can see that they love open questions, important information such as the slur speech, any arm weaknesses, vision changes, and detailed systemic review, just to rule out the myasthenia gravis, MNT, MS, potential like trauma or masses in the brain. Examination was good. I did the arm neurological examination, including sensations. I didn't have enough time for a facial exam, and he did put some feedback on that, but it was a minor issue. Out of 3 points, so 3 is his best, 0 is the shittiest one. I got 2, so it's a okay, generally okay examination. Very empathetic, non-verbal communications. Ding! Quite easy. And IEC, they like eyes a lot. The clinical management and other things we'll talk in the other videos, okay? The second one was a bowel obstructions patient. The patient had Crohn's disease, went through tons and tons of abdominal surgeries, so potential adhesions causing small bowel obstructions, so vomit and constipations. But I thought it was upper GI, but we'll talk about that in the next video as well. Station 3, it was a explanation of OGTT and GDM, so gestational diabetes to a mom. But we'll talk more on the communication skill stations. But you can see that there's nice open questions. We still ask a little bit history on there. And going on to station 4, it was explaining atypical UTI to grandma about the management and the treatment afterwards. The history was okay, and other things, everything is explained. Very good, easy and simple. Station 5 was a Crohn's disease. And this history was the best one, I suppose, because we checked the blood and mucus, so the specific one to check whether it's a Crohn's or ulcerative colitis, as well as we checked for eyes and joints, so other symptoms that could present if the patient has IBD, as well as recent stopping smoking. So if a patient has ulcerative colitis and recently stopped smoking, they will have flare-ups, but this patient doesn't have it and he has Crohn's disease. So covered quite well, good explorations, and examination. I didn't lie the patient flat because usually I don't have time to play around with the bed. But then see that the examiner was saying that I didn't check the patient's face while palpating. But I did! You can't see my little eyes. So actually turn your head and look at the patient, okay? So that they know that you are actually checking the patient. And this is the thing that I was mentioning about, is that when presenting the history and examination findings, you would say that you would check the hernia orifices and PR, but you won't do it obviously, but you would check. A6 was a PVD, so peripheral vascular disease. And this one was the one I was mentioning about. So I checked the pulse, but I say it in a very low confidence way. So I think I feel the pulse on dorsalis pedius, but I don't feel any posterior tibial pulse. And the consultant was quite cruel. So he double checked. Huh? No pulse on dorsalis pedius? Yes, pulse on dorsalis pedius, but no pulse on posterior tibial? Are you sure? I had to like change my answer back and forth. I can't remember what answer I give at the end. But then checking the post exam is very important, and make sure that you know where you need to check for dorsalis pedius, okay? And I forgot to ask the patient to walk. I forgot. And then this one was, what's this? This one was the mental health. So this station was a probably 30-ish years old female, 5th time coming to the A&E. I'm a mental health doctor liaison team. I'm there to assess the patient. The patient keeps complaining about palpitations and heart problems. She wants to see cardiology, but I haven't seen them. It requires a lot of empathies and explanation on, like, I know you got heart problems. You feel like you got heart problems, but sometimes moods can affect your heart, whether it beats faster than normal. And from your blood results, it has all shown normal. So that's why I'm here to double check that, make sure that that's all right. And I'll be able to pass this information to cardiology. So the mental health history, if the patient doesn't like your existence and doesn't understand your existence, you need to justify why you are here and why you need to take a history on mental health. Finally, Station 8 was A to E assessment. The patient is 50 years old male with recent vomit of blood. And the reason why I check is there any recent increased alcohol intake? And he does. He said, I've been drinking 5 pints of alcohol, 5 pints of beer every day for the past week. And that's a huge, massive risk factor for upper GI bleed, right? So that immediately triggers the potential need of major hemorrhage protocol. So that's why sometimes asking specific questions. I don't think I asked any smoking problems because, well, I think I did. But I skipped certain parts of the history because those are not important. In this kind of short time exam, so in 18 minutes, you need to do A to E assessments. There's not much time for you to take a full history that you need to ask the specific history taking. But a little bit more details on A to E assessments is in the next video, I think, or the 3rd or 4th video. So I'll talk more on A to E assessment later on. So I've showed you my results on history taking examinations. So we'll now go on to how I prep in 3 minutes time. I'll just briefly show you, and we won't make too long, and we're almost done here. So if let's say we got this vignette, I'll write down the patient's name. Let's say John Smith, 73, so that you make sure that it's on the top. So when you present the history to the examiner, you don't have to go back to the vignette again to check what the patient's name and the date of birth is or how old he is. Shortness of breath. So I will write down the presenting complaints. So presenting complaints, and then Socrates. And then I'll write what kind of things I think might be going on. So the system-wise, we'll do cardiovascular, respiratory, potential cancer, and then I saw furosemide, right? So I'll write heart failure here. Sorry, this pen is massive. Heart failure here. So that means that after asking the Socrates for shortness of breath and checking the cardinal symptoms for all of them, if I haven't asked the heart failure specific questions, I'll double check that, or ask cancer. If I think there might be an infection, check infections. What else could cause peripheral vascular disease? Or anemia, right? Anemia. So any pale in your body. So some specific symptoms, and then eyes, I'll draw a line so that I'll do a signposting. Past medical history, drug history. I sometimes forget allergies, so I'll double check that. And then family history of it, social history. And then another line, examination, so that I don't miss anything I want to check. So this is quite a simple one, isn't it? So we'll we'll have a look at another one. Let's have a look. So this one is difficult walking. This will be fun. So I got a lot of things on my table. You can see that it's my pad, my mouse. So I swerve my hands around my table so I don't hit anything and I have to refilm my video again. So this patient, let's say his name is Chris. He's 43 years old, male, right? Difficult walking, so walking. So you need to check why he has difficulty walking. Is it because of weakness? Is it because of pain? What is it? Why? And it could be MSK, it could be neuro, it could be cancer, so like a mass in your leg, or trauma, all kinds of things, right? And then if you draw a line, then you start thinking it could be MSK, right? MSK could be like osteoarthritis, pseudogout, all kinds of things. You start writing the potential conditions that you think might be going on. And neurological, it could be MND. He's quite young, but whatever. MS, MG, stroke. What else? PD, yeah. Difficulty. What else? Hypoglycemia? Not really. Infection, or DVT, or potential vascular problems like PVD, fracture, those kind of things. And then we ice him, and then signpost, plasma history, drug history, social history, family history. And over here, he says that he's not currently taking any medications. So don't ask about drug history. Just say, on the record, it says that you're not taking any medications. Is that correct? Are you allergic to any medications? That's fine. And then examination, we might need to do, sorry, the paper is a bit small, but examination will do probably neurological symptoms, neuro, or leg exam, so leg MSK, or pulse exam. Potential DN foot, we might need to do that. But those are the things that you would consider before walking into that room and seeing the patient. Okay, so that's how I prep during the 3 minutes. For the last 3 years, since I started doing OSCE Mosler, I have never used BNF when I was outside waiting, other than A&E, A3 assessments. But you feel free to use it because it's there. And if you got time, just rest, take a deep breath in and out, because it helps activate your parasympathetic nerve, makes you feel calm, so make you think sharper. So we have done most of the things already. Now it's more of my own personal take on this experience after failing my first attempt and passing my second attempt. These are all the things that I improved and changed. So first of all, avoid thinking and code checklist style. So what it means is that in the UK, examiners prefer you to make it more of a communication, chatting while gaining your information, compared to more checklist style, like yes, no. Sometimes I don't know what the patient has, so very vague symptoms. I go on to very checklist style. It will be like this. So any shortness of breath? No. Any heart problem? Any chest pain? Any cough? So I bombard the patient, bam, keep asking. But I know it's quite hard to not do that, but then just still, I think the way to say it is that you do bombard the patient with yes, no questions, but then if sometimes the question is too much or starts to jump, so you jump from head and then start asking about vaginal problems, just explain to the patient why you are asking, so that you allow the patient as well as the examiner know that why you are asking it, and it won't be the patient just being interrogated and sitting there and like saying yes or no all the time. for the think more focusedly, don't take systemic inquiry that much, is because when I first going to GP the first time in year 3, there was a patient with allergic rhinitis. Like, I didn't know much about allergic rhinitis. I know that it just leads to your coughing and sneezing, right? So I asked all kinds of problems. The patient is 55 years old, female. And I remember that I asked her everything from head to toe. So from headache, all the way to the bowels and urinary problems, as well as menopause symptoms, because I think she might be experiencing it, and potential diabetes as well. It was horrible. Like, when presenting the history, it was horrible. The presentation took me probably 2 minutes to finish saying everything that I asked, and that was embarrassing. So don't do that. Even though we sometimes are asked to do a systemic inquiry, but still try to think why you are asking it before you ask it, okay? The third thing I want to say is that previously I used to write things down when taking histories, and I do know that there's a benefit of it because you don't forget it. But what my take is that when you do that, you're doing this. So any shortness of breath, or you'll be like, any shortness of breath? No shortness of breath. Any cough? No cough. There are two disadvantages of it. First of all, you break the flow of it. You're more of compared to a continuous history taking that makes the patient feel better, as well as it takes quite a lot of time when writing things down. And I know the benefit of it is you can think while writing it, as well as not forgetting it. But after trying both sides, personally, I think not taking notes is a better way, because usually it's quite easy to remember the history. I can still remember most of the history from my exam. So I suppose you are able to do it as well. So my personal preference is that I think not taking notes. So you can still write notes during the prep time, but then don't do anything. So just taking histories and think while asking stuff. It gives you more time and it gives you a better flow to it. If the patient is chatty, obviously you ask yes or questions. If you want to interrupt them, when they are taking a breath in between the sentence, just say that, oh, sorry to interrupt, I want to ask, or sorry to interrupt, but I want to double check, then you bring the patient back again. In terms of open questions, I just say like, how can I help? Or tell me more about it. What brought you here to the hospital? So that's the first open questions, the first two open questions. After that, you don't really need open questions anymore. So 2 open questions maximum, and then after that, it's just more yes/no questions, okay? Other than how it affects your daily life, that's probably quite an open question, isn't it? I was told by my senior, so a friend of mine who is currently a F1 doctor already, so he's 1 year above me. He was saying that your history has to be convincing that it's most likely something. Like, after finishing taking your histories, your history should be clear that what the most possible cause of it is, because the symptoms, risk factors, and examination fits it. And in terms of differential wise, you with those informations, you're able to present it to the examiner, so that even though it might be wrong, but then at least the examiner knows that, okay, fine, like, okay, with a cold leg, powerless leg, and you check and pain around the leg when walking for a long distance, and when examinations there's no pulse, then it sounds like peripheral vascular disease, isn't it? Even when I'm calling on the phone, after me saying all these informations, the person on the other side will be thinking like, oh, this is probably a peripheral vascular disease. So have a mindset that your history should be convincing, even though it's an examination, but try to make it as convincing enough as possible. And we mentioned about Socrates and more structures. So the main reason why you want structures is because you want the examiner sitting at the side to be able to follow your thoughts. That's something that they want. They want to know that what you're thinking so that they can happily take and give you marks. So that's why structure is very important. The most difficult part of me failing the exam, so after I failed the exam, I'm starting to recollect all my knowledges and study again. The most difficult part is that I have to accept that I didn't have structure, or my structure is not good enough. And accepting your own failures, taking in as much feedbacks as possible, compared to me arguing like, I did this already, I asked this already, it was you who didn't listen to me. Truly accepting it makes you improve much faster after a failure. So that's my general take on history taking, the structure part. Finally, final few things is don't repeat that much. After your signpost between the eyes and the past medical history, you don't need to signpost anymore. Stop signposting for everything, unless you feel like the patient might not understand why you're asking. So for example, if you're asking sexual health history, then you might need to signpost. But other than that, you don't need that much of a signposting because it takes too much time. So previously I used to do like, we'll go on to head-to-toe assessment, we'll go on to past medical history, we'll go on to drug history, social history, That's too much already. That's too much time. And don't do it too fast is something that I noticed in my first attempt. There was a female patient, 30 years old, no, 27, and she went to France for skiing, fall and hurt her shoulder. The x-ray in France was normal, but she still noticed the pain in her right shoulder, so that's why she came to the A&E. It was quite a simple one, simple history, right? Shoulder, bro, like it's not likely to be osteoarthritis, isn't it? Because she's 27. It's most likely a muscle tear or a potential infections. So two differentials and very unlikely for potential cancers. But that's all, isn't it? And a fracture. So the history was really fast. I swept it like lightnings. And I did the examination like fluently, like a pro. Feel, moving it, checking the powers. I had around 3 minutes to 4 minutes at the end. So in 15 minutes, I finished history taking / examination at 11 minutes. I just sat there in silence with the examiner for like another 4 minutes before he could start asking questions and he could start talking. And he was not happy about it. Even though the feedback was okay, but then the history taking was out of 3 points, I got 1 point. Examination out of 3 points, I got 1 point. I don't know what was wrong, but I can only imagine that it was me like doing things too fast. And he feels like, I don't know, but just don't do it too fast, okay? So that's everything I know about history taking and examinations, including in special histories, right? In the next video, we'll talk about the interrogation period where you have to talk to the examiner about what you think might be going on and the area where they are most likely to deduct your mark. So we'll talk more on that in the next video. And if you have any questions or concerns about history takings or examinations, feel free to comment below or send me a message. I think I'll leave a Google document in the description as well. But thank you for watching and I'll see you in the next video. Bye bye.